We'll get started very shortly. And there we are. Hello, everyone, and welcome to the webinar, What's New with PARP Inhibitors and Ovarian Cancer. I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer, Patient Support and Education at SHARE. Before today's program begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Now I'm going to go over some housekeeping items. All participants will be muted during the presentation. Once Dr. Herzog finishes presenting, we'll begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember, Dr. Herzog is unable to give specific medical advice, so please keep your questions general. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. And we'll also email it to all of the registrants. Now I'd like to hand it over to today's speaker, who we're so excited to have join us today. Dr. Herzog, would you mind introducing yourself?
Thanks, Maggie. Yeah, hi. How's everybody? Yeah, I was laughing when you said I couldn't give any medical advice. I just got done with morning clinic, and they probably said the same thing. So hopefully I'll be able to give some advice that's helpful to you all. So we appreciate you being here today. I am a G1 oncologist in Cincinnati. I served as the deputy director of the Cancer Center at the University of Cincinnati. And full professor. I came from Columbia University, where I was the division director and fellowship director at Columbia and Cornell. And prior to that, I trained and spent forever at Washington University in St. Louis, where I was also the fellowship director and then was recruited to New York. And then back here to Cincinnati, which is my hometown, to be the deputy director of the Cancer Center. So that's who I am, G1 oncologist. I do a lot of research. As you can see, I have lots of papers and all that kind of stuff, lots of grants. Had a lab for a while. More importantly, though, currently I serve as the GOG Foundation president, which is GOG's over GOG Partners, which does most of the industry drug development in North America. As well as we now have sites in Brazil, Korea. We're working on Japan, and we have a liaison committee with NGOT in Europe. So we have most of the globe covered in terms of large studies that are done. Most of the registration trials that you see in G1 oncology over the last 5+ years have been with us. We're also over the G in energy. And we just finished our energy meeting in Orlando this past weekend. So it's been a busy week coming back from that with clinic and surgery and so forth. So that's who I am, Maggie. So back to you.
Great, thank you. So yeah, if you want to go ahead and get started with the presentation.
Great. All righty.
Looks good.
Can everyone see the slides okay?
Yep, looks good.
Okay, so Great. So for those of you on here, I think what I'll do is a lot of this is on there for background and that. I'm going to sort of keep it at a high level. Try not to get too much into the weeds. There's some of you who are probably interested in some of the weeds. So every now and then we'll take a dive in where I find it interesting or where I think it might be enriching for you to have a little background. Otherwise, what I'll do is sort of maybe even skip some slides, but I'll just tell you why they're in there, and so we can look at them as we need to, as we move through here. So don't get too frustrated if we move around a little bit as we go through here. Okay. So start here. Okay, so those are my disclosures. I'll leave them up for a second so you can see. And my role with drug development, obviously a lot of advisory boards, pipeline consultations, and so forth in terms of trying to bring these drugs to our patients. And that's a whole long story that maybe one of the questions will come around and we'll talk a little bit about. So we're going to talk about PARPs. And PARPs have largely been relegated from, and I'll explain the process, but they've largely been relegated from just treatment to more of a maintenance phase, and then some treatment as well. And so I'll explain what all that means. But what is maintenance? Maintenance is where we give additional therapy after we give chemo, and we usually have completed the surgery and then the chemo, and then we move on to give something additional to try to keep the cancer from coming back and maybe even cure. So the thought process is if we know that up to 75% of the patients with advanced stage disease, stage 3 or 4 at diagnosis, which is the vast majority of our ovarian cancers. And when I say ovarian, some of you will say, well, I had fallopian tube or I have primary peritoneal, all in the same family. And I'm using ovary as an umbrella term here today, just so that makes sense to you. And so why would I possibly want to get additional treatment? Well, if you know the cancer is going to come back at 3 out of 4 patients is going to come back in, at least, why wouldn't we try to do something different? And up till now, I could have taken you through the maintenance of the history of maintenance and everything, but to shorten this talk, I took all that out. But suffice to say that we've done other trials where we've looked at prolonged Taxol, we've looked at other agents, and they haven't really shown an impact on overall survival, nor a real strong impact on progression-free survival. So those are two terms we're going to throw around a lot today. Progression-free survival simply means from the time that you go on to, in the case of a study, when you go on that study until there's evidence that the disease has come back or progressed, so progression-free survival, or death. Overall survival is looking only at death, and that death could be disease-free survival, meaning ovarian cancer death, or it could be someone got struck by lightning at their golf course, or they got in a wreck, or they died of heart disease or something else. So we look at both of those numbers very closely to try to understand how we can make treatments better over time. And the real optimism story about all this, if you take anything else home today, is that when I know I look old, I'm in clinic, it's been a long week, but I'm not that old. And I started doing this, and the median survivals were 18, 20 months for advanced stage ovarian cancer, overall survival. And now we're looking at where many women are well beyond 60 months plus. So tremendous improvement in where we've been with increasing the prevalence of the disease, so much so that this is no longer considered to be an orphan disease by the FDA, which kind of stinks because that was a nice shortcut to get trials done quickly because we could have less numbers and so forth. But it's the good news is it's because we're keeping patients alive for so much longer than we ever have in the past. And so while the incidence has gone slightly lower, not much, the prevalence has gone up significantly due to the fact that more women are alive than there have ever been in the world with ovarian cancer. So that's a good news thing. getting back to this maintenance story, the idea is, what are the reasons why maintenance might work? So ovarian cancer is a relatively chemosensitive disease. We have lots of tumor that's often in there at the initial surgery or the initial diagnosis. And frankly, getting back to the history of this, reason why maintenance didn't work before is because our drugs just weren't good enough. Now with the PARP inhibitors, it's quite a different argument. We'll look at that. And a lot of this is the idea of getting rid of these clones that are resistant. So these resistant clones from which the disease emanates. And cure is part of this in terms of, could we cure more people with being able to give maintenance therapy? All right, so we spent a lot of time on that first slide, so we gotta get rolling here. But this is to give you some idea of what we're talking about. So the treatments there in that green curve that goes down like a waterfall, or like you're going down a big hill or roller coaster, shows to where you get down to disease that you can no longer see. Limit of clinical detection is that white dotted line up there. And so you can see what happens naturally is the gray line. So the disease is very low, and then those tumor cells start multiplying, and then you're up into where, you have billions and trillions of cells, and then that finally becomes able to be diagnosed clinically. CA-125 is elevated, or something we can feel on exam, or something we can see on imaging. The idea of maintenance therapy is to try to keep that down. So it goes down there, and then we take that minimal residual disease and try to take it down further with that maintenance therapy. And that's really the idea behind all that. So what about PARP inhibitors? This is a slide I hesitated to show, but I'm going to tell you that there's probably at least 10 different pathways involved in DNA repair that are important. These are probably the 5 most important pathways. And one of them repairs. So when DNA tries to replicate, it creates nicks that create single-strand breaks, or 2 nicks in strands that are parallel to one another that create double-strand DNA breaks. And so cells are constantly doing this. They're constantly repairing in the body. They face a lot of stress, external stress, sunlight, tobacco smoke, alcohol, who knows what's in our foods, all the things, bacteria, everything, viruses, everything that your body gets exposed to, that's stressor that your DNA has to react to, repair, and so forth. And just to maintain the cells growing, even if you had a low stress environment, no viruses, no bacteria, you're still going to have DNA repair. These cells need to replicate and refresh. And so what happens with the base excision repair pathway on the far left is that's related to single-strand DNA breaks. What's important is PARP inhibitors interfere with that repair process, okay? And they can bind the enzymes, if you will, that are responsible for that. In the case, and that's the key single-strand DNA repair system, okay? In the double-strand breaks, there's a thing called homologous recombination. And I know we're getting into things we don't want to get into, but what's important is this repairs double-strand DNA breaks. And guess what's important here? BRCA mutations, RAD51, all these homologous recombination related genes that are responsible. Now, the bad news is if you have those genes, you're more likely to get cancer. The good news is that those genes, if you already have a defect and then you pair that with a PARP inhibitor, you can actually kill cancer cells more frequently, okay? The reason you end up getting more cancers is because if you can't repair double-strand breaks with homologous recombination, that HR at the top there in orange, you shift to these non-homologous end joining, alternative end joining, and they have really low fidelity. In other words, they make a lot of mistakes. So the proofreading goes out the window, and you make a lot of mistakes, and you become cancer prone. Again, in cancer cells, we can then use the PARPs in patients who have BRCA1 or homologous recombination deficiency from other reasons, such as loss of heterozygosity and some other DNA things that can happen, that actually give us a therapeutic opportunity to kill cancer cells at a much higher rate than we would with traditional chemotherapy alone. So that's a great thing. So is there one universal approach to look at this? Well, if you think about it, starting on the bottom, we used to think, well, PARP inhibitors are probably going to work in those with these BRCA mutations, right? Right. So if your mom or your father passed along these mutations, meaning their germline, then we know that's about 15% of the population. What we didn't realize fully was that 7-8% more will have spontaneous mutations that give you a BRCA mutation test positive situation by what happens during the course of your lifetime. So you develop a new BRCA mutation. So you didn't get it from your mom or dad, but the tumor now has it because it's developed on its own while tumor was forming. You then look at these homologous recombination genes, and they bring it all the way up to 35%. Then if you look at what I call loss of heterozygosity and other things, you now have 50% of the population that would clearly benefit from a PARP inhibitor. It's about 52%, and some of them 48%, so you get the picture. So the role of PARPs has expanded tremendously. And then we have some studies where people are HRD test negative, meaning there's no BRCA mutation. None of these tests came up positive. They still benefit from a PARP. Why? Probably false positives for the HRD tests. Okay, and we can get into that a little bit. So, I think we've gone into enough of this, but this just shows you the different etiologies of what makes up that pie. And you can see on the far right, those that are homologous recombination proficient should not respond to a PARP, but some of them do. And I'll show you examples of that in clinical trials, probably again because of those false positives. Everyone else in that pie graph there, a little over 50% on this one, would likely respond to a PARP. So where did this all start? Well, it goes back quite a ways. It's been 15 years. Where we've looked at the first data that really came out, and it was phase one. Phase one, as you know, is for patients that are getting usually experimental type drugs, and we don't know the right dose, and we don't even know if it's the right disease. But sometimes you hit on a winner, and I've got many examples I've known over my career where the first person's in the Gleevec that had gastrointestinal tumors, and they were cured, and some of the hematologic malignancies where we've seen that. This is such an example. And you wouldn't see too many phase one studies in the New England Journal of Medicine. It's just that this was such an impressive mechanism of action in terms of how it worked. And it worked so well when it works that it made it in as a phase one study, which is really impressive. And you can see the clinical activity there with CR meaning complete response, PR meaning partial response, and SD meaning stable disease. So look at all the responders that were there. And those are platinum sensitive patients on the left, platinum resistant patients. Still a lot of them responded, not so many with refractory, meaning that you grew through frontline platinum. So really impressive for those patients. Now, this brings us to who should be tested. Everyone should be tested who has epithelial ovarian cancer. And there's different ways of doing it and so forth. We don't have to get into that, but everyone should be tested. These are how good the benefit can be. Just briefly, what do we learn by testing? We can tell what the likelihood of your journey would be. We can never say what one person's journey can be, but we can say with pretty good certainty what if we took 100 patients with certain characteristics, what their journey is going to look like collectively. And as I said, there'll be some that don't respond like they should have, and there'll be some that respond much better than even the average of what we see in that 100. But generally, we'll get a pretty good idea when we look at large numbers and we look at this, and we know those with BRCA mutations have better prognostic outcomes, meaning they live longer. They respond better to these DNA damaging drugs for those reasons I talked about in that first couple slides there with all those pathways giving you headaches again. We can also predict the likelihood of response to DNA damaging drugs, such as PARP inhibitors. And so we would then use this as strategy to help the patient have exposure to better treatments. It also helps us screen in the individual patient. I saw a patient in clinic this morning who's BRCA and has not been following up on breast cancer screening as we had prescribed, and really counseled her pretty tersely that, hey, this knowledge is power, and that we're able now to, with this information, prevent you from having breast cancer. And she could consider risk reduction measures. There's all kinds of things to do there. But, this all got picked up from her ovarian cancer. And then really importantly is this saves lives. So we're able then to contact family members, find out if they indeed have these mutations that have been passed on, yes or no. And if yes, avail themselves to these risk reduction surgeries, risk reduction medications, and much better and closer follow-up to try to catch these cancers early if they don't avail themselves to some of the other modalities that we have to reduce their risk. All right, so this is the first treatment, if you will, that came out, and as you can see, quite a bit later. So 2009, phase 1. Now we're at phase 2, and I think this is animated, so it goes pretty fast. Let me go back one there, but just shows you that they had a 26% response rate, including platinum-sensitive and resistant patients, which was pretty impressive for a single drug. And here's where we are now. So primary therapy. For Frontline, we're going to talk a little more about, and then platinum-sensitive recurrence. And these are the bulk of our indications for PARP inhibitor use right now. And these are the different trials that have been done with the different PARP inhibitors. And I'm going to sort of take you through each of these and show you what's been done here. So Solo 2 was a maintenance trial that looks at olaparib versus placebo. And these are in patients that had platinum-sensitive relapse. And there's really, I got a nice table that summarizes all of them. So in the interest of time, what I was pointing out was you can see the difference in MDS there is 8% if they had the PARP versus 4% if they did not have the PARP. And so certainly, we have to be mindful of this and in terms of the toxicity from these for long term, because that's obviously something that we want to avoid. So Solo 3, we'll skip that. Nova was the study that was done with niraparib in platinum-sensitive disease, and they really had 2 cohorts. And you can see these are big trials, 553 patients randomized to niraparib versus placebo, 2-to-1, niraparib being the PARP. And again, these are patients that had platinum-sensitive recurrent disease, meaning that it had been more than 6 months since they had recurred, and they are then placed into this study. And we'll show you the results from these. And you can see here the big difference between these curves. Look at how big the differences are. So if progression-free survival is 21 months versus 5.5 months. Hazard ratio below 0.3, meaning you have a 73% improvement in the risk of progression or death. You can see the p-value, highly statistically significant. And you can see the landmark analysis, sort of which curve would you want to be on? Well, at 12 months, a year out, 62% of the patients are doing great, 16% in the control arm. At 18 months, 50% are still doing great, 16% still in the control arm. So not so good. And you can see the different subgroups here, whether the test for HRD positive or negative is there. You can see the patients that are HRD positive do much better, as we would predict based on those pathways I showed you, those repair pathways at the beginning of the talk. HRD negative, there's a benefit, but it's only less than a few months. And the hazard ratio is okay. It's pretty good, but the final on that was 0.68. Aerial 3 was another one that was done with a different PARP, rucaparib, which has been on and off the market as their company went bankrupt last year or a year and a half ago. They're now back with Pharma and getting remarketed and retooled. with a phase 1 study we can talk about that should be out this year. So again, you can see these curves, best for BRCA, slightly less for HRD, and then not quite as good in the intent to treat population, but even there it looked pretty good. And here's all the curves and all the different studies. So Ariel 3 was rucaparib in the orange, and the blue is Nova, which was niraparib, and in purple is Solo 2, which is olaparib. And then there was a phase 2 study, 19, that included all subtypes because Solo 2 only did germline BRCA mutated patients with a handful of somatic mutations that were in there. But you can see, look at the placebo, you can see that all those are pretty close. They're around 5+ months or 5 to 5+ months. And then you can see the tremendous improvement based on the different subsets. And again, if you have a BRCA mutation, the most benefit from a PARP. Wildly crazy hazard ratios, almost down to 0.8, meaning 80%, 80%, or 0.2, meaning an 80% improvement in outcomes. Versus if you're just HRD positive, still very good, but not quite as strong. But still, you're seeing hazard ratios below 0.5, still very impressive. And then you get into the all-comers where they actually tested negative for homologous recombination deficiency, and there's still some benefit with 0.68, and I'll show you some later data in our frontline trials. So this is the newest and greatest data. This is the data that's all come out in the last few years. And the first one, we compare it to GOG 218 because that's bevacizumab. So that's another maintenance strategy, right? Bevacizumab by itself. Solo 1 was a study that was conducted solely in those who had BRCA mutations, okay? They could have germline or somatic. Most of them are all germline. PRIMA was a study with niraparib in high-risk women. We'll show you the data from that, but took all comers in terms of molecular subtypes. And PALO 1 was bevacizumab plus olaparib. And again, very large trials, GOG 218, 1,800 patients, PALO 1, 800 patients, PRIMA 733, Solo 1, 391. So big trials. You can see how you can't completely compare these because there's some differences of when the clock starts. GOG 218 started right after the surgery when they went on to their chemo. These PARP trials started after they had a response to frontline platinum, and then at the end of that, they got randomized to maintenance platinum or placebo, but they had to have a response. So that's one of the criteria that was in these trials. Okay. Different thing about PALO 1 is that it's an active comparator because the only one that didn't go up against placebo because it was olaparib plus bev versus bevacizumab, okay, which is an anti-angiogenic agent, meaning it keeps new blood vessels from forming, which we previously had shown improves progression-free survival in ovarian cancer. So these are the types of patients that you see in these trials. The worst population was PRIMA because they eliminated patients that had been debulked down to no gross disease in stage 3. They excluded them because they were trying to get their endpoints to occur quickly so they could catch up on the trial. You can see slightly different ways of testing for HRD. And I talked about the randomization point being different for 218 previously. You can see neoadjuvant was not allowed in GOG 218, meaning you give the chemo before the surgery. You can see the highest rate of stage 4 is done in the PRIMA trial. So just get a feel for these different trials. And here's the numbers from these trials. So these hazard ratios, they tell you what's going on across the entire curve rather than just the median. So if people say, well, the median that's just at where 50% of the patients fail therapy, or therapy fails them rather, you see that line versus the hazard ratio really looks at what's the difference across those curves across their entirety. And you can see, again, same principles. If you have a BRCA mutation, these are all the BRCA mutated patients, of which Solo 1 was only those patients. So solo one kind of drops out comparison-wise after this, okay? But the hazard ratio was an incredibly impressive 0.33. We have long-term follow-up that looks really promising that we're super excited about. So these, again, are the patients that are BRCA wild type, meaning they did not have a mutation, but they were HRD test positive. Again, look at these hazard ratios, 0.5, 0.43, really impressive. Bev doesn't help, it doesn't make a difference if you're BRCA mutated or HRD positive with bevacizumab, but it does for the PARPs. And these are the patients that do not test positive for HRD, but you still see some advantage here. Not for the Apollo 1 where Bev was in the control arm, but you do for Prima. And we'll show you some other data that gives you some pause too. So this is Solo 1, and the reason I'm showing this is more recent data. It was updated. But I want you to look at those curves. They're just not going down. And we're now out at 96 months on this plot, out to almost 100 plus months. And you can see those curves aren't going down. This begs the question, are we curing more women with ovarian cancer with this strategy in patients with BRCA mutations? The answer clearly, I think, is going to be yes. This is the olaparib plus Bev, the longer term data, and you can see again, when you get out towards 6 years, 5 years and beyond, there's a sustained benefit, even though you only gave the PARP, in this case, for 2 years. So sustained benefit there. Niraparib, this is some of the follow-up data for the longer look from the Prima trial. And again, we're seeing those curves flatten out nicely. Okay, so we're excited about that. Safety profile, I think most of you are familiar with the differences between some of these different PARPs. But the big thing is bone marrow, diarrhea or GI fatigue. And those are the big ones that we usually see. And you can see the highest discontinuation rate was with where we gave PARP and bevacizumab at the same time. But otherwise, these drugs are pretty well tolerated. Again, looking at the side effect profile. And then I mentioned the MDS and AML. But the more common things are there in the purple and the blue. Those are the more common things that we see with these PARP inhibitors. Okay. One other trial, this is what I was talking about with rucaparib, was a frontline trial. This is the Athena mono, which we'll have the data on, meaning that it's also a part of this is being done with an IO, meaning an immune oncology drug. So it's also being given with nivolumab, but we won't have that readout for probably another year and a half or so. But you can see here that we'll have updated readout on overall survival very shortly. And we had the original readout on PFS that was in at ASCO now over not this past one in June, but the one before. So coming up on a year and a half. So here you see the different, again, with the frontline trials, you can see the medians. You can see what the medians and hazard ratios are if they're BRCA mutated. And I've added in another one. I snuck another trial in on you. Prime, that's a trial with niraparib from China that also looks very promising. And if you look at the HRD test negative, impressive hazard ratio, impressive. And we see pretty good hazard ratio with Athena, 0.65, although again, the median is not that great. But look at the big differences, you know, in those that are BRCA mutated in terms of outcomes. Really quite different in terms of PFS. All right, so we have all these, you know, these guidelines now that sort of tell us what to do, and it would probably take us, you know, 10 minutes or so to go through all this. But it's all based on this data. It's all based on Prima, Solo 1, Prima, GOG 218, and then the same trials. So the big decision first is, are we going to operate first or not? Are we going to do neoadjuvant, or are we going to do primary cytoreduction? Second thing we're going to think about then, are we going to do bevacizumab? Yes or no? And then what is the molecular marker? If the molecular marker shows BRCA or HRD, we have certain options. If it's HRD test negative, we can still use a PARP, in this case niraparib, versus the others. Olaparib is used with the Bev. So there's a lot of different things based on the indications from these trials that make a difference. interest of time, I'm going to skip over some of the resistance mechanisms and so forth here, so we can get to the questions. So some of the things that happened that later on, I started off with saying we've been relegated to frontline maintenance, platinum sensitive maintenance, and not so much treatment. And that's because we use treatment, in this case, olaparib, which showed very good progression-free survival. But what we started looking at was overall survival from these, and found that if you had not been as heavily pretreated, you did really well in terms of overall survival. But heavier treatment, those patients didn't do very well. Hazard ratio actually went the other way, 33% reduction in the risk of death. And so this started generating Dear Healthcare Provider letters. So the DHCP, Dear Healthcare Provider letter, and they started coming out for all of them. Now, we don't necessarily feel that this is something that is a real phenomena, because there was so much crossover to PARPs in these patients. So it's not like we had one population that had PARP and maybe got more PARP, and then another population where they didn't have that. Instead, it was incredibly high crossover rates as time went on because of the success that patients and their doctors had seen with the PARP inhibitors. So the patients that were in the control arms ended up getting PARPs. So it's a little hard to account for when you look 4, 5, 6 regimens down the lane and try to attribute it, oh, it must be the PARP that caused that problem. So we started seeing that with all the aerial 4. This was rucaparib, same problem when they got to platinum resistant. The hazard ratio was 1.5. They didn't like that, so they pulled that one and got a letter. Then we saw Quadra with niraparib. They didn't care for this either because, again, the heavily pretreated patients didn't like this. So we spent the better part of the last year and a half pulling different indications. So these are the approvals now, and if you can see the slide very well, you can see the crossouts. So treatment indication for olaparib, we crossed it out for a number of those things. In the treatment indication, they're pretty much gone. Maintenance, they've extensively limited that as well, to largely BRCA patients in the platinum sensitive setting. So that's been a big problem too, and they've further taken this table from here to where we are today, with those being fairly limited to just BRCA mutated patients, in some case HRD. You might be able to get through, but no treatment there anymore. Now, where are we going with all this? And this is really, I think, important as we look at this into the future. And really where we're going with this is combinations, okay? So I mentioned the Athena mono, which we have the data, but we'll be getting the Athena combo, where we have the checkpoint inhibitor nivolumab, which turns the immune system on against the cancer cells. It removes the brakes that shouldn't be there, because your immune system should recognize those cancers as foreign. But unfortunately, that doesn't happen sometimes, and that's what allows the cancer to proliferate. So that's why these checkpoint inhibitors have been highly successful in many diseases. You've heard of things like Keytruda. We don't usually use brand names, but people probably start nodding their head. Oh yeah, I've heard of that. We call it pembrolizumab, but you can see that's in some of these trials as we move forward here too. So a number of very interesting trials that have or will report within the next year, year and a half. So again, we're super excited about this. We got a press release on the FLAURA5. This is a monoclonal antibody to CA125. And we've seen a long history with this: negative trial, positive trial, negative trial, positive trial, negative trial. Every time we do the bigger, more registration type trial, it becomes negative. And unfortunately, FLAURA5 was sort of a last ditch effort to do the trial the right way. And we don't have the data yet, but the press release is that it's a negative trial, which is very unfortunate. We were hoping that would not be the case. Duo has reported, and this is the trial, and this reported at ASCO this past year. So in Chicago, this is the data that came out. And you can see that what they did is they used in the orange, the maroon, or the maroon rather, not the orange, the maroon, you can see they used bevacizumab as maintenance, a checkpoint inhibitor, durvalumab, and then olaparib, a PARP inhibitor. So 3 different drugs versus in the second one, they did the bev and the durva with no olaparib. The olaparib was a placebo. Personally, I don't know. They didn't do the olaparib bev arm alone, which would have been much more informative. And so it's a little hard to know what the contribution of the durvalumab was in this. And so these are the different arms here. I'm not seeing a big difference between the black and the blue curve there. Maroon curves clearly separates from the control arm, but for me, I'm not seeing a huge difference. But we're still working out subsets and so forth to sort of see how this goes. So we're interested in these other trials where maybe we might get a better understanding of the contribution of the checkpoint inhibitor or the immune drug. And so what we expect, Keylink, a lot of these are GOG trials, as you can see, will come out, and then we'll see the Athena combo, Nirvana. And so, part of the problem is that we didn't have an olaparib only arm in Palo 1, and then we didn't have the checkpoint inhibitors. So we're going to have a lot more information. And as I said, all these are going to report very soon. So we're excited to see all this new data. My concerns obviously are toxicity from combining all these drugs, not only physiologically or biologically, but also financially. So we'll see where it takes us. But just wanted to wrap it up here to allow ample time for questions. So maintenance has really given us a great strategy for ovarian cancer treatment now that we have an effective compound, class of compounds with the PARP inhibitors. Till then, maintenance was not looking as favorable as it could or should. So we're excited that the PARP inhibitors have arrived and finally made maintenance therapy effective. Biomarker development is very important as we move through this, and we're starting to understand the subsets from all these trials that have reported, such as DUO-00, but we'll also see the subsets from all those 4 or 5 other trials that we'll report shortly. Some at SGO, some at ASCO this year, some at ESMO this year, and then some in the next year. But we'll have all those done. We should have almost all those wrapped up in about a year from now. And it'll not only be the primary analysis, but also these subsets where we look at these different biomarkers to best understand who benefits from these different drugs and in what combination. So that's really key. Talked about combinations in the next bullet point there with antivascular drugs such as bevacizumab, the immuno-oncology drugs, and the PARP inhibitors all being combined or as doublets. We have to look at the cost effectiveness and the clinical value, such as toxicity and everything else. We've really seen a transformation, though, in the outcomes of frontline ovarian cancer with PARPs. There's no doubt in my mind they should be used sooner if the patient's a candidate, not saved for later, because the hazard ratio is basically a percentage of what the gain is. And in frontline, the difference is you can see that the numbers are so big, so you're getting where you're up to 30, 40 months, that type of thing, you're getting that percentage of that gain versus when you recur, you get much smaller in terms of benefit. You make it the same ratio, but you're looking at less than 1/3 of the number of months that are realized. So I think it's important to use these drugs in frontline. Surgery is still really important for ovarian cancer patients, and maximal removal of disease is still critical in my opinion. I'm still concerned by the FDA's stance on OS pushing the PARP only to almost frontline in some platinum sensitive indications. And we may get more data from these trials that we see a change in label once again. So we'll see what happens. And again, I want to thank everyone who's ever been involved in a clinical trial, because you're the one that's bringing new knowledge and gives us new options as we are here today. So thank you for doing that. All right, Maggie, I'll turn it over for any questions that we have.
Great. Thank you so much for that presentation and being able to hop back on so we could now begin the Q&A discussion. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as possible, but we may not be able to get to all of them due to time constraints. So by far the most asked question is really around how long to stay on a PARP inhibitor, especially the safety and benefit of taking one for longer than, say, 2 years. So how long should patients stay on a PARP inhibitor?
Yeah, I knew this would likely be a question. It's one that I get in the clinic every day, so
I'm
I'm
sure.
surprised by that. Thanks for bringing that up. Um, we don't know, is the answer.
Hmm.
We, these numbers were plucked rather arbitrarily, just like Bev was given 18 months. All the PARPs were given for 2 years, except for niraparib, which was given for 3 years. So, do we know the answer as to which is better? We don't. I think we'll get some more long-term follow-up from Prima, which will be helpful in terms of, what's that doing to our MDS, myelodysplastic syndrome, and AML rates, which would really be the main concern because, as you know, patients that are on it 2 years, 3 years, they're usually tolerating it pretty well. The ones that didn't tolerate it very well have long been weeded off. So they're usually tolerating the drug pretty well. They've learned how to they've learned how to adapt and bring it into their life so that it doesn't, they've learned when to take it relative to food, relative to bedtime, for sleep, and for lack of nausea and things like that. So we're really usually in pretty good shape with these patients. So I think the real question then is how do you make that determination? And I think that for me, it's a shared decision making where I talk to them about the pros and cons. I had a patient last week who's, had really high risk stage 4 ovarian cancer. She's in a number of support groups. She's very nervous about coming off. I said, well,
Hmm.
we don't have to. She's on one of the 2-year PARPs. I said, well, look, niraparib data is out to 3 years. Why don't we do another 3 months and see how we feel?
Hmm.
And my goal is to get her off by 3 years, but we'll see where that goes. But I have niraparib patients that have insisted on staying on, and I've done it.
Hmm.
Um, so I think it's really an individual decision until we have more data. In general, I think you're probably safe to come off by 3 years. Are you safe to come off by 2 years? You probably most certainly are, and so much so that there are some people proposing a study right now of looking at 1 year versus 2 years.
Mm.
So,
Okay.
yeah, so that gives you some safety if you're like, look, I really don't, and a lot of patients are like this. I don't really feel myself. Yes,
Hmm.
I've learned how to control the symptoms, but I don't feel 100% myself. If that's the case, and it's 2 years, I would come off.
Hmm. Okay. Yeah, and so sort of along those lines about people who maybe don't tolerate it as well, we're also getting a question around reducing the dose and when patients have to do that, and how confident are you in the efficacy of lower doses, or how do you feel about that?
Yeah, so for me, I think it depends on where we started. So with niraparib, you may or may not be familiar with, but we do individual starting dose based on the weight of the patient and the platelet count.
Hmm.
So if you're small, we started at a lower dose, and platelet count was low, we started at a lower dose. Having said that, if we're then coming down another dose just because you don't feel well, we're now at like a third of the dose.
Hmm.
That makes me nervous.
Hmm.
But other than that, that first dose reduction, we're probably fine. These are drugs that bind at a very high affinity and probably do their job at that first dose reduction. Coming down 2 dose levels, we just don't have the data. But I have
Hmm.
no problem coming down one dose level, if it helps tolerance and keeps
Mhm.
patients on the drug.
Mhm.
So going down 2 doesn't mean that it won't work. It's just that we don't have data to back it up.
Okay, great. Thank you for that. And then we're also getting a lot of questions around like PARP inhibitor use when there's not a genetic mutation or other biomarker present. So, what are the considerations of using a PARP inhibitor in those instances?
Yeah, so you have, say Frontline, for example, you would have the option of no maintenance, not doing anything, and then you're sitting there with the going back to the beginning of my talk. Well, you say, well, you're just going to have a 75% chance of this coming back, and you're not going to do anything about it. But I have many patients that that are frail, that barely got through the chemo, and they just don't want to do anything else, and that's fine. But most do, in which case then if they're HRD negative, BRCA wild type, meaning they don't have a mutation and
Hmm.
their HRD test is negative, you have the option of niraparib by label, or
Hmm.
you can do bevacizumab. So those are your 2 options there. The hazard ratio is pretty similar for the clinical benefit. The hazard ratio from that PRIME study, which is another niraparib study that was done in China, looks much better. And then the rucaparib looked good, reinforcing the idea that you probably have a 30+% chance of reducing your risk of progression. Now, can you do Bev plus PARP? You would be off label in that circumstance. The Bev plus PARP, and specifically olaparib, based on the Apollo 1 study, is the indication there. And that's only for those that test HRD positive. So
Hmm.
that's sort of where that puts that. So it becomes a discussion with your physician, what you think you're best going to tolerate, how's this going to affect subsequent treatment, and so forth. But there's certainly a strong rationale for going on to a PARP, and slightly less for me, but still there is going on bevacizumab.
Hmm. Hmm. Okay, great. Thank you. And then it looks like there may be some confusion about the role of folate receptor alpha. So I just maybe you could clarify how that does or doesn't play a role with PARP inhibitors.
Doesn't play any role at all. So folate receptor alpha is a target that's overexpressed in about 80% of ovarian cancers, but highly overexpressed in only about 30 to 40% of ovarian cancers. And mirvetuximab soravtansine was recently had the data come out at ASCO, and the accelerated approval had occurred previous to that, and then the pivotal trials come out, and so people are using MIRV, as we call it, in the
Hmm.
platinum-resistant setting for treatment. So it has nothing to do with maintenance, it has nothing to do with PARPs.
Hmm.
And so that's where testing can be done. And it can be done up front so that we know whether that's a candidate, whether you're a candidate for that. Some of the other antibody drug conjugates, of which MIRV is, are in studies looking at using cutoffs that are lower than that 75% expression for folate receptor alpha staining.
Hmm.
So you'd
Great.
want to, again, talk to your doctors if you're in a platinum resistant setting for what trials are out there with such agents.
Hmm. Great. Thank you for that, for clarifying that for people. Um, If the cancer recurs, should the same PARP inhibitor be used?
If you tolerated it really well and you didn't progress on the PARP, there's absolutely no reason to go to switch.
Hmm.
If it gets a little fuzzier than that, the interval wasn't as long as you'd like, and maybe you had some side effects, I'd probably try a different one. Biggest reason to switch would be for symptoms, though. We think the toxicity profiles are slightly different. We don't think there's a big difference in efficacy between the 3.
Mhm. Okay, thank you. And then this person is asking for your thoughts about long-term super responders and ceasing treatment
In what? In what?
and going off treatment.
Yeah, did it have a number? I'm trying to see which one it was.
Uh, I think this person has been on it for almost 10 years.
Yeah, that's certainly it, going back to that discussion of, after 3 years, you're probably in good
Yeah.
shape. After two, you're probably fine as well. I think 10 would be, yeah, I'd come off.
And unfortunately, we're almost at time, so I am going to try to get through one or so more questions, but I'm just mindful of that. And so, just wondering your thoughts on PARP after PARP.
Yeah, not a lot of data. There's limited data. Oreo study, if you want to look up a study, it looks like Oreo, showed that data, but it's pretty small cohorts. If you believe in PARP after PARP, it reinforces it. If you didn't, you'd say these are unicorn patients, and it doesn't change my opinion. But for me personally, if I have a patient sitting in front of me, I will give them the benefit of the doubt if they have BRCA mutation or HRD positive. I make them prove to me that their tumor is not going to respond before I dismiss a very, very effective agent. So, did they progress on a PARP? If the answer is no, I'm probably coming back to it.
Mhm. Great. Thank you for that. And it looks like we're at time. So I guess I just want to end it with, is there anything else you think that you think we haven't covered, or anything that you're particularly looking forward to seeing the results on in the realm of PARP inhibitors, or just anything that you want to add?
No, it's just that clinical trials are really what it's all about. And if we can, in your groups and that encourage clinical trial enrollment, it's really how we make the most progress the quickest. And so I think that's really incredibly important. One question here, real quick. PARP's ever appropriate for low-grade serous? We don't have any data on that because they grow it a very different way. And then it says, or primary peritoneal. Remember, primary peritoneal I included in ovarian. So primary peritoneal cancers can respond to PARPs, but the low-grade serous histology, we usually don't. Thank you, Megan.
Yeah.
Appreciate it.
Yes. Well, thank you so much, Dr. Herzog, for such an informative program. And thank you to everyone who participated and submitted questions. Again, I'm sorry we weren't able to get to more of them today, but I'm sure we'll be doing more programs like this in the future. Make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. Please take a moment to complete the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be sent in a follow-up email. All surveys are anonymous, and we really use that feedback to inform our programming. This concludes today's webinar. Thank you again.
Thanks, everybody. Bye-bye.
Thank you.